So in the last recording yesterday, we were talking about kVp, and we ran through some kVp questions. Those questions being, how do changes in kVp affect X-ray production? How do changes in kVp affect penetration? How do changes in kVp affect patient dose? And if it does affect patient dose, what kind of techniques are better for patient dose? We talked about whether or not anything could compensate for lack of penetration, that being mAs or the computer algorithm, and how do changes in kVp affect occupational dose, and what precautions are best for technologists. We asked too, how do changes in penetration affect scatter radiation, scatter creation, scatter incident on the image receptor? How does scatter affect contrast and latitude? How does scatter affect density? What is the preferred method to control scatter or control density? As patient size changes, as tissue composition changes, what is the best way to control density? So we looked at a couple of graphics. We looked at how you, as a technologist, receive your radiation dose, that being all off of scatter radiation. We looked at a graphic about how kVp adjustment affects transmission through the patient, photoelectric interaction, Compton, and the composition of the beam as it exits the patient. So as kVp increases, we increase numbers, and I refer you again back to the BREM spectrum. We get a lot more X-rays created, and we get a lot more X-rays emitted, but the X-rays that we create and especially emit are of higher energy, so we get more penetration. A higher percentage is penetrated through the patient. Again, looking at 50 versus 120 kVp. At 120 kVp, we get a much higher percentage of transmission through the patient. So as kVp increases, what really changes is frequency and wavelength. Thinking back to the first semester when we were talking about electromagnetic energy, which is what X-rays are. They're a form of invisible light. As kVp increases, what we get is an increase in frequency because the wavelength gets shorter. So X-rays and gamma rays are very high frequency, short wavelength, as opposed to other forms of electromagnetic energy are shorter wavelength and longer wavelength and lower frequency. So as kVp increases, the percentage of Comptons increase, the percentage of PEs decrease. Really, the absolute number of PEs increase, but the percentage of PEs decreases. And what I mean by that is, again, think about your BREM spectrum. You've got, in the BREM spectrum, the average beam energy is only 1/3 of the peak energy. So 100 kVp X-ray beam, the average energy is, and most of the X-ray photons are going to be 33 kVp. So 33 kVp doesn't penetrate through a lot of things. So even inside of the patient's body, it doesn't penetrate through a lot of things. So the highest number of X-ray photons being at 33 kVp at the average, a lot of those are going to absorb inside of the patient. So as we increase our kVp, the absolute number of photoelectrics increases, but the percentage of what's left penetrates through the patient at a higher rate than what they would at low kVp. All right, so percentages of PEs decrease, but absolute number increases. Percentage of Comptons, on the other hand, remains pretty consistent throughout the exposure. That's percentage, but the absolute number of Comptons increases dramatically, and the percentage of transmission again increases according to the chart 2 slides prior to this one. As kVp increases, so we say that PEs decrease. What we're talking about there is really the percentage. So as kVp increases, the percentage of PEs decrease. PEs are the largest contributor to patient dose. So if we increase our kVp and we reduce our mass, then we reduce the PEs that are going to take place in the patient's body, and the patient dose will decrease. If we increase kVp only, then patient dose goes up dramatically. If we increase kVp and reduce mass, increase our kVp by 15%, reduce our mass in half, then patient dose will decrease. It won't decrease by a factor of 2. It won't decrease by half, but it will decrease. So the effects of kVp is, on the X-ray beam, is that we have more penetration. We have fewer interactions of all types. The Comptons decrease, but the PEs decrease much more rapidly than the Comptons do. So the Comptons remain somewhat consistent. There's a narrow window that as kVp goes up, the Comptons decrease, but they don't decrease a whole lot. But the PEs decrease far faster than what the Comptons do, and so we get more penetration through the patient. More penetration of all tissue types means that we're going to lose contrast. Lower kVp, we get an increase in differential absorption, and we get high contrast. With high kVp, we get a reduction in differential absorption, more penetration of all tissue types, and contrast goes down. So kVp in large patients, we need enough kVp to penetrate, and then we want to use mass to compensate. But the downside to using mass to compensate is that the patient dose is going to increase pretty dramatically. So we can compensate with kVp, but think about what kind of tissue that we're adding whenever we have large patients. It's primarily going to be soft tissue. Soft tissue, we get an increase in scatter radiation. So if we have a large patient, we increase kVp, again, our change in scatter radiation, our effects on scatter radiation, almost become exponential, and we don't want that. Scatter is fog. Fog covers up sharpness of recorded detail. Our visibility of recorded detail goes down if we increase kVp. Therefore, we want to use mass, but the patient dose does go up. Effects of kVp, changes on the image. In a practical standpoint, in clinical practice and in clinic, and what you're going to observe on your monitor is that there is not much of a change if you change your kVp within 15% up or down. But again, the registry still says kVp is the technical factor we use to adjust contrast, so that's what we have to learn and understand. So again, when you're reading test questions, make sure you understand the test question. What technical factor changes contrast? Your answer is kVp. What controls your contrast on a digital image? That would be your computer algorithm. So look for technical factor in the question. Technical factor is going to be your kVp. So in that way, because we lose differential absorption as kVp goes up, we lose differential absorption, contrast goes down. As kVp goes up, we get less contrast because we get less general absorption, less differential absorption, and more scatter radiation. So in context of this slide and what it's asking there is it's asking about an increase in kVp. So if you decrease kVp, the exact opposite would apply. If you decrease kVp, your contrast goes up. You get more general absorption, you get more differential absorption, you get less scatter radiation, and that the result on that is an increase in contrast. So understand that. There's only one slide here, so understand that this is going in one direction, and if you went in the opposite direction, the opposite of each one of these bullet points would be true. Density or exposure to your image receptor. providing the only thing that you adjust is your kVp, your density or your exposure is going to go in the same direction as your kVp. You increase kVp and your exposure to the image receptor increases. Remember, density equals exposure, so density theoretically goes up. Again, your density is really going to be controlled by your computer algorithm, by your lookup table. So increased kVp, what we get is a decrease in contrast and an increase in image receptor exposure. So realistically, what you're going to see on your image is a change in your index number. If you increase your kVp by 15%, your index number is going to tell you overexposed, or your exposure to the patient went up by a factor of 2. 15% increase in kVp equals a doubling of the mass as far as image receptor exposure goes. So your S number or your index number will show that you overexposed or you increased your exposure by a factor of 2. Sharpness of recorded detail with kVp changes remain unaffected. Visibility of recorded detail, you might see a slight change in contrast. It's not going to be real significant though. So your S number indicates exposure. Sharpness of recorded detail unaffected by kVp. Visibility of recorded detail, you've got maybe a slight change in contrast, but it's going to be pretty insignificant. So, affects kVp on interactions. To sum it up, increased kVp, we get more X-rays produced, we get more X-rays transmitted, so we get fewer percentage scattered or absorbed. However, we get exponentially fewer absorbed than scattered. So the percentage of Comptons increase, the percentage of photoelectrics decrease. So what we wind up with is more overall scatter and a decrease in contrast. So your exposure will increase if kVp is the only factor that's changed. If you're truly using your 15% rule and you increase your kVp and you decrease your mass, if you increase your kVp by 15%, you reduce your mass, cut it in half, then your image receptor exposure remains the same. If you decrease your kVp, all of this reverses. So if you decrease your kVp, you produce fewer, you transmit fewer, you scatter and absorb fewer, really, but you're going to have more absorbed than scattered. The percentage of Comptons is going to decrease. The percentage of photoelectrics will increase. Overall scatter is going to decrease and contrast is going to increase. So mass. What is the questions for mass is, what does mass affect in the tube? Primarily it's heat production, but it also affects the numbers in the X-ray tube. So as we increase mass, we increase the number of electrons that we create. We increase the number of electrons that we create. We increase the number of photons that we create. But how that manifests itself in the X-ray tube itself is just with heat. In the patient, because when we increase mass, we increase numbers. In the patient dose is going to go up, and it's going to be proportional to the change in mass. If you expose the patient with 1 mass exposure and they get 5 milliroentgens off of that 1 mass exposure, or rad off of that 1 mass exposure, and you double it, then you double your patient dose. If you triple it, you triple the patient dose. So there's a direct correlation between mass and patient dose. So sharpness of recorded detail, you can actually affect sharpness of recorded detail with your mass in 2 different ways. One we already talked about, and that is with the blooming issue. Actually, we've talked about both of these, but primarily with the blooming issues, what you've got is you've selected too high of an MA station, or you stood on the rotor button too long so that you overdeveloped your space charge. And the blooming is the focusing cup's failure to adequately contain the space charge. So remembering that there's only a 15 kV or a 15 volt charge applied to the focusing cup. If you apply too many electrons because of the law of electrostatics, if you try to compress too many of those electrons together with that minimum charge of 15 kVp or 15 volts on the focusing cup, it doesn't take a whole lot of electrons to overcome that. So when you apply the kilovoltage in that small space that they're going to travel from the cathode to the anode, they're going to expand out. And technically speaking, what you've got there is off-focus radiation. It's not generally what we refer to as off-focus radiation. Off-focus radiation is where an electron bounces and it is reattracted to the anode and you create X-rays somewhere else. But really, technically, what you've got there is off-focus radiation. Don't confuse the two. When I ask about off-focus radiation, I'm talking about the bouncing electrons. But technically, if you're thinking, okay, well, this is X-rays, these are X-rays created off the focal tract, so they are off-focus radiation. Yes, it is. But for our purposes, off-focus radiation is not blooming. Blooming's something totally different. So the other thing is focal spot selection. Focal spot selection is going to be restricted on large exposures. When you get back into clinicals, you should play around with your X-ray tube. So turn off your APR and start selecting technical factors. If you select 400 mA on a small focal spot, your machine will most likely give you a tube overload. And that's to protect the X-ray tube against unreasonable exposures. It's unreasonable to ask a small focal spot to give you 400 mA. So the machine will disallow you from doing so. So your focal spot selection is going to be determined by the MA that you can select. If you select 200 mA on a small focal spot, it'll allow you to do that. But chances are at 300 mA or above, you can't select small focal spot. So in that way, MA or mass can also affect your ability to select a focal spot size, and in that way affect sharpness or recorded detail. But generally speaking, whenever we're talking about mass and sharpness or recorded detail, we're really talking about blooming issues. So visibility or recorded detail only in the extremes. If you again get into the toe and shoulder portion of the H&D curve where you've got extreme over or under exposure, can you affect visibility or recorded detail? But that's only in the extremes in mass. So what is mass control? In the tube, numbers of electrons, that's your current. So it directly controls the number of photons in the patient. The exposure, sharpness, or recorded detail can be affected also by motion, but that's really if you use long exposure times, sharpness or recorded detail also blooming. But you can control your motion by using reciprocity, increase your MA and decrease your time. And then at the image receptor, we got exposure to the image receptor. Mass is what we want to use to control exposure to the image receptor. So if we've got adequate density and your index number shows that you've underexposed the image, then what you need to do for your repeat is increase your mass. So are there times to change kVp and mass? Yeah, there are. We'll walk through some scenarios. So what we'll talk about is are the changes in kVp and mass and their effect on scatter, the effect on density, the effects on sharpness, recorded detail, visibility, recorded detail, and the effects on dose. So patient thickness. How do changes in patient thickness affect X-ray production? We have to consider, are we phototiming or are we setting a technique? Do changes in patient thickness affect penetration? We have to consider patient dose issues, and we also have to consider occupational dose as well. What kind of patients increase and what kind of tissue types increase patient dose the most, and what types of tissue types increase occupational dose too. So how do changes in patient thickness affect scatter radiation? Are those photons more likely to penetrate or be absorbed? What percentage will increase in the remnant beam in penetration or scatter? And what does that mean to image receptor exposure? So what are the options for compensating for changes in thickness? How do those compensations affect image quality, specifically kVp? Will other steps be needed? How does scatter affect contrast? How does scatter affect density? So backing up and going through all this. How do changes in patient thickness affect X-ray production? They don't. What you do with your machinery is what affects your X-ray production. Just by virtue of standing a patient up in front of an image receptor, you don't have a change in X-ray production. When you're phototiming, your machine makes the compensation for you. If you go from an asthenic to a hypersthenic patient and you're setting a technique, you're going to have to increase something, preferably kVp, because you went from asthenic to hypersthenic. You went from not much soft tissue to quite a bit of soft tissue. As we increase kVp, our percentage of scatter increases in the penetrated X-ray beam and covers up our sharpness of recorded details and destroys our visibility of recorded detail. So, as a result, we want to increase mass. But when you're phototiming, the machine takes care of that for you. So I'll refer you back to all the discussions we've had about phototiming before. A phototimer is just a photon counter. So if you take a asthenic patient and put in front of the phototimer, and your phototimer is set to terminate the exposure at 5 MR exposure to the phototimer, that's not to the patient, but to the phototimer, it's going to send a signal to the timer circuit to discontinue the exposure when it receives that 5 MR. If you put a hypersthenic patient in front of it, it does not recognize the change in patient size. It's still waiting for that 5 MR to send the signal over to the timer circuit. The difference is going to be it's going to take longer for the patient or for the phototimer to receive that 5 MR because the patient's going to absorb more X-rays. The hypersthenic patient being thicker, they're going to absorb more X-rays. So what's going to happen is the mass is going to continue to build, mainly unless you're working on a falling load generator, which I'd refer you back to last semester to review that. Unless you're working on a falling load generator, your timer just continues with a set MA. So your mass value builds until that photocell receives that 5 MR, and then it sends a signal over to the timer circuit to discontinue the exposure. When you set a technique, though, you would need to increase your mass. So how do changes in patient thickness affect penetration? How do changes in thickness affect patient dose? Well, we just talked about that. When you go from a single asthenic patient to a hypersthenic patient, what's going to happen to your mass? Mass is going to increase. Whenever you phototiming, the phototimer takes care of it, but mass increases. What's the main thing that drives patient dose? It's mass. So what happens whenever we have a change from a asthenic patient to a hypersthenic patient? What's going to happen to the patient dose? The hypersthenic patient is going to receive more of a dose. So how do changes in thickness affect occupational dose? Well, you might be thinking it doesn't really, but again, I'm going to refer you back up to this graphic here. What is your main driver of occupation? Well, I won't even say main driver of occupational dose. The only thing that affects your occupational dose is Compton scatter. What type of tissue creates more scatter radiation? It's soft tissue. So are you going to get more scatter radiation off of an asthenic patient versus a hypersthenic patient? Well, it depends. Which patient is going to create more scatter radiation? Well, it's a hypersthenic patient because of the soft tissue. So of the tissue types, or of the patient types, a hypersthenic patient is going to cause a higher occupational dose. So how do changes in patient thickness affect scatter production? Generally, as patient thickness goes up, we're talking about soft tissues, so we get an increase in scatter production in soft tissues. Are those photons more likely to penetrate or be absorbed inside of the patient? The answer to that is really more will be absorbed inside of the patient, but what penetrates is more likely to be scattered in a hypersthenic patient than in a patient who is asthenic. So what percentage will increase in the remnant beam, penetration or scatter? As we go from an asthenic patient to a hypersthenic patient, we're more likely to scatter. It's just law of averages. If you have one layer of soft tissue that you're trying to penetrate, that's just one layer of atoms that the X-ray photons can interact with. And if you have two, then there's two. If you have four, then there's four. If you have 100, then there's 100. So thinking about your interactions inside of the patient, each time you add a layer of soft tissue, one more layer of soft tissue, or one more thickness of soft tissue, you're adding possible interactions inside of the patient. So your photoelectrics are going to decrease and your scatter is going to increase. Now some of that scatter, I want to expand on this a little bit, some of that scatter will be absorbed inside of the patient and won't penetrate through the patient, and therefore your exposure to your image receptor decreases if you don't adjust your technique. Yesterday's recording, I'd mentioned that you're going to have a tendency to confuse scatter radiation in hypersthenic patients and equate that to fog. Fog, you're going to equate to a layer of density, and you're going to have a tendency to think, well, a hypersthenic patient creates more scatter. Scatter is fog. Fog is density. You need to decrease your technique for a hypersthenic patient. But you have to understand that a lot of the scatter that's created inside of the hypersthenic patient will be absorbed because of the multiple interactions inside of the patient. So your emitted beam, your remnant beam, the intensity of the remnant beam actually decreases. And in that decrease, you need to increase your mass. But what's left in that remnant beam is primarily scatter radiation. So what are the options for compensating for changes in thickness? Primarily you want to use mass, but you can use kVp, but if you use kVp again, you compound the problem of scatter. So as thickness goes up, if primarily it's soft tissue, you really don't want to increase kVp unless you absolutely have to. Yesterday I'd mentioned using limited exposure X-ray machines like a portable machine, and you can use kVp when mass is inadequate. I think I've related a story before where I was working in surgery and we were doing a lumbar laminectomy on a patient who was so wide, literally he was as wide as a horse. And we were using a portable machine to localize where the surgeon had placed a towel clip on his lumbar vertebra spinous process. So we maxed out the machine at 80 kVp at, I think it was 2 or it might have been 400 mass, trying to get a high enough exposure to localize this towel clip. And we couldn't do it. The beam just wouldn't get through the guy. So we increased our kVp to 100 kVp, and the maximum mass value we could use was 100 mass. And we actually had to double expose the patient in order to get a dark enough density to visualize. So it was basically 100 kVp at 200 mass. But it was an ugly image, even using a grid to clean up some of that scatter radiation. It was a hideous image, but we just couldn't do it with compensation in mass, so we had to use kVp. So there comes a time when you might have to rely on kVp for changes in patient thickness, but most of the time, if you can, you need to use mass. So kVp is possible. Reduction in SID is another possibility that you could use. Neither one of those are ideal. You would really want to use mass. So how does patient thickness affect scatter? We've kind of done that to death. How does scatter affect contrast? Scatter destroys contrast. That's why we don't want to use kVp whenever we have an increase in patient thickness. How does scatter affect density? It lays down a layer of density, but again, I don't want you to confuse the increase in patient thickness with scatter creation and scatter creation with increase in density. Scatter is a layer of density. It's an unwanted density on the image receptor. So in patient thickness, we're really talking about tissue thickness, but tissue thickness can be specific to a body part. And what I mean by that is you can have somebody who is relatively sthenic but have a large anatomy of some sort. So the same things really apply there, though. Most of the time whenever you have an increase in tissue thickness, you've got soft tissue. What is the soft tissue composed of, though? Is it soft tissue? Is it fatty tissue? Is it muscular? Seldom is it bone. The thickness of the bone usually doesn't change a whole lot unless you've really got some bad pathologies like a cancer that eats away at the cortex of the bone. Most of the time the size of the bone doesn't change, the composition does. So as tissue thickness goes up, relative to the anatomy that we're x-raying, patient dose goes up as well. It affects scatter in the same way that patient thickness goes up because scatter, the percentage of the scattered that composes the remnant beam increases, contrast goes down, grayscale goes up, density goes down if you don't adjust your technique. Sharpness of recorded detail remains unaffected, and visibility of recorded detail goes down. Anything that extends grayscale and reduces contrast gives you a longer scale of contrast, gives you a lowered visibility of recorded detail. So because contrast, grayscale, and visibility are already affected by tissue thickness, then the technical factor that we need to adjust is the one that does not also affect contrast, grayscale, visibility, and that would be we want to adjust our mass. So I'm going to stop this recording here and I'm going to pick up with field size.